So you have a 50-year-old male who presents with unexplained anemia. His CBC shows microcytosis and hypochromia, but he denies blood in his stool or GI symptoms. Which of the following tests should be ordered next? Remember this. I know all of you are thinking about colonoscopy, but remember that in the answer options, colonoscopy was not provided. So if colonoscopy is not in your answer list, what is your next best step? That's the question I'm really asking about. After you've done your colonoscopy and maybe colonoscopy comes back normal, what's your next best step? A, bone marrow biopsy. B, serum ferritin and iron studies. C, hemoglobin electrophoresis. And D, reticulocyte count. What is your answer? So let me see the answers which are coming. Some say they are going to do hemoglobin electrophoresis. Others say they are going to do bone marrow biopsy. Others say they are going to do serum ferritin and iron studies. Others are saying they are going to do reticulocyte count. So what is our answer? So what will we do? Remember that in this case, I've told you, we know it. In this case, I would have done a colonoscopy, but colonoscopy is not in my answers. So chances are that we did a colonoscopy, it came back normal. What will I do now? The next thing I'll do will be to do serum ferritin and iron studies. So I do my CBC, hemoglobin is low. Next best step, do colonoscopy. Colonoscopy comes, it's fine. I'll do my serum ferritin and iron studies. Most of the time, when you're even doing your CBC, when you have an elderly person and CBC, hemoglobin comes back low, the lab will automatically send the request to the hematologist and for them to look at, ferritin and iron studies anyway. But I'm just saying so that you don't get confused. That is why in the answer section, you remember, look at the down there. I've put do colonoscopy first. If you have a patient with anemia, next best step, who is older, 50 years and above, do your colonoscopy. But after colonoscopy, what else? You do your serum ferritin, you do your iron studies. Okay, ferritin and iron studies are used to confirm iron deficiency, which is the most likely cause of microcytic anemia in this patient. Okay, and that is why, if you remember the objectives, they were also talking about the fact that you need to know microcytic anemia, you need to know macrocytic anemia, you need to know pneumochromic anemia, because based on how the patient presents, that directs you. If the patient had presented with macrocytic, macro, big, and you were doing ferritin level, I'll go like, man, doctor, what are you doing? Right? Because it does not go together. But since the question is talking about microcytic anemia, so assuming I do my microcytic anemia evaluation, I do my iron studies, what else do you think I'll do? Knowing very well I now know the cause of microcytic anemia. Who can help me? I do my blood work. The patient has low hemoglobin. The patient is 60 years. I do a colonoscopy. I get the patient to see a general surgeon or a gastroenterologist. The general surgeon or gastroenterologist says the colonoscopy was normal. I do my serum ferritin and iron studies. They also come back normal, but the patient has microcytic anemia. Doctors, what do you think I'll do next?
Transferrin and TIBC.
Okay, sure. Assuming you did that as part of your serum ferritin and iron studies, because usually when you're doing iron studies, they do TIBC and transferrin levels. I'm just talking about this in relation to the other causes of microcytic anemia.
A reticulocyte count.
Capsule endoscopy.
Anemia of Crohn's disease.
No. Doctors, let's keep it simple. Okay, let's start. What are the causes of microcytic anemia? You said iron deficiency anemia. What else?
Thalassemia and anemia of chronic disease.
Sideroblastic anemia, anemia of chronic disease.
Lead poisoning.
Lead poisoning. Okay, sure. So I've done my colonoscopy. It came back normal. I've done serum ferritin, iron studies, total iron binding capacity, transfer. Also normal. What other tests do you want me to do?
Electrophoresis.
Globin electrophoresis.
Upper GI endoscopy.
Electrophoresis, upper GI endoscopy.
Endoscopy,
Will I
yes.
check my lead levels as well?
Yeah.
Lead levels, yeah.
Good. Will I also go on to check like kidney function test, liver function test? Yes. Because anemia of chronic disease can also be, right? So now I have to widen the way I'm going to investigate the patient, but my investigation should be based on the fact that I know the causes of microcytic anemia. Doctors, are you getting it? So you're not just requesting the labs for requesting sake. You are requesting them because, okay, first, 60-year-old has anemia. I've ruled out GI malignancy. Now, I was thinking about iron deficiency anemia. I've ruled that out. Now, what are the other causes of microcytic anemia? I've said lead poisoning. So will I check my lead levels? Yes.
Yes.
Will I
Renal function
do an
test.
assessment, check for other causes of chronic disease, kidney function, or liver
Kidney
function?
function.
You know, I'll even do my A1C. Does the patient have diabetes? Does the patient have diabetic nephropathy, which is leading to iron deficiency anemia? You know, or which is leading to anemia because of decreased erythropoietin levels, right? So I want to do all those things. So I want to say it again. Elderly patient anemia first. Please do your colonoscopy first. All right? Good. Next question. I have a 30-year-old woman with a history of pica and restless leg syndrome and is evaluated for anemia. Which of the following lab results would support a diagnosis of iron deficiency anemia? A, high MCV, normal ferritin. B, low hemoglobin, low ferritin. C, normal hemoglobin, high reticulocyte count. D, high hemoglobin, high ferritin. So someone is asking on YouTube, didn't get the point. Why will we do colonoscopy first? I think this is the commonest thing we've all discussed in MedCognito. If you have any patient who is above 50 who develops anemia and you don't know the cause of the bleeding, please do a colonoscopy to rule out GI malignancy and GI bleed. That is why we are doing it. So Dr. Reka, we are doing the colonoscopy to rule GI malignancy and GI bleed out before we even go on to do any other thing. Okay. So what is the answer? Is it low ferritin, low hemoglobin, high MCV, normal ferritin? What's our answer? The answer is obviously B. In iron deficiency anemia, there will be low hemoglobin and low ferritin. So low hemoglobin, low ferritin are diagnostic of iron deficiency anemia. Ferritin is sensitive marker of iron stores, and low level strongly indicates a deficiency. Okay, high MCV, mean corpuscular volume, suggests macrocytic anemia, and that is more of vitamin B12 deficiency, alcohol use, right? Normal hemoglobin, high ferritin is more suggestive of anemia of chronic disease. So low hemoglobin, low ferritin, think about iron deficiency anemia. Low hemoglobin, high ferritin, think about anemia of chronic disease. High MCV, mean corpuscular volume, think about vitamin B12 deficiency. Okay, you have a 65-year-old man with chronic kidney disease and anemia, has a serum ferritin level of 100 and a transferrin saturation of 15%. What's the most appropriate next step? A, oral iron supplementation. B, intravenous iron therapy. C, erythropoiesis stimulating agent. D, bone marrow biopsy. Looks like a lot of people are going for A. And what's the answer? B, in CKD with functional iron deficiency. So it says the patient has chronic kidney disease and anemia and has a serum ferritin level of 100. Okay, so you go for B because in CKD with functional iron deficiency, intravenous iron is preferred to oral iron. If the patient did not have kidney disease, you might have gone for oral iron, but oral iron is less effective in CKD patients with functional iron deficiency. That's the main thing. And erythropoietin, you can't just give erythropoietin without giving adequate iron replacement as well. Okay, and bone marrow biopsy is not indicated. So in CKD, remember, in CKD, the patient goes on to develop iron deficiency anemia. You also want to pay attention to probably getting the patient some IV iron therapy because that helps better than oral iron supplementation. Okay, now you have a 47-year-old woman who presents with unexplained fatigue and microcytic anemia. Her ferritin is 150 nanogram per mil, and CRP is elevated. Which condition is most likely contributing to her anemia? A, iron deficiency anemia. B, thalassemia. C, anemia of chronic disease. And D, vitamin B12 deficiency. Remember, the patient has microcytic anemia. So I have a question. Which of these four will you rule out right away just because of microcytic anemia?
D.
Which one?
D. B12 deficiency.
D. D. So you rule out B12. Okay.
Yes.
So just
B12.
because of microcytic anemia, you're going to rule out B12. Beautiful. Okay. So doctors, you see how things are going. Just because we saw the word microcytic anemia, we've ruled out B12 deficiency. Okay. What is the next expression we are going to focus on? CRP is elevated. So what does that lead you to?
Like a chronic condition.
Yes.
Inflammation.
Yeah.
Inflammation, any autoimmune disease.
See that thing, eh? Okay.
Inflammation.
So what then is your answer?
Anemia of
Anemia
chronic
of chronic disease.
C.
You see the way we did it. So you see, just 2 words: microcytic anemia with CRP elevation. Of course, iron deficiency anemia will present with low iron deficiency anemia will present with microcytic anemia. Thalassemia will present with microcytic anemia. Anemia of chronic disease will present with microcytic anemia. But what in the question stem sets anemia of chronic disease from the others is the CRP elevation. What in the question stem helps you to elevate vitamin B12 or eliminate vitamin B12? Microcytic anemia. Doctor, so you realize that in your MCQE1, every word matters. Every word. And that is why the one who said D, all of them come to class. They know these tricks. We teach them all the time. So they go into the question like detectives, right? Okay, I see this, I see that, therefore it can't be this. So you've already ruled one out. Now you have left with 3 of them. What did we say? In anemia of chronic disease, is ferritin elevated or decreased? Who remembers? In anemia of chronic disease, is ferritin increased or decreased?
Increased.
It's increased.
Increased. Beautiful. So a ferritin level of 150 is high, not low. So it makes iron deficiency anemia less likely. And then we also said the patient's CRP is elevated. Iron deficiency anemia does not lead to elevated CRP because iron deficiency anemia by itself is not an inflammatory thing. Oh, my people. So you realize that then it makes anemia of chronic disease most likely. Elevated ferritin with microcytic anemia and elevated CRP suggest anemia of chronic disease. So let's write our equation. In fact, let's take our time and write our equation. Oh, where are we? Okay, slide 69. Let's go. Doctors, you see, it's necessary that at times you take your time to learn some of the concepts. So what did we say? Anemia of chronic disease. What is our equation, please? Can someone help me?
Ferritin levels will be high.
High ferritin.
Yes.
Okay.
Yes.
Plus
MCV low.
Elevated
MCV
CRP.
down. MCV low.
Low MCV, mean corpuscular volume. Then plus what?
Hemoglobin low.
CRP.
Low hemoglobin. And then plus what?
High CRP.
Elevated
High
CRP.
High CRP.
Simple. Write this equation down, chew it, memorize it, put it under your pillow, put it on your fridge. Wherever you are going, remember Dr. Bruni told you this. Boom. Anemia of chronic disease. There we go. Doctors, QE1 is doable. QE1 can be conquered. Please. I love you with all my heart, and I really want to make sure that everybody does well. So you have a 50-year-old woman who has anemia with hemoglobin of 8 grams per deciliter, MCV of 72 femtoliters, and then RDW of 18%. Which of the following findings would further support a diagnosis of iron deficiency anemia? So you see, you may think you know iron deficiency anemia very well, but until you've taken your time to go through a lot of questions, doctors, please don't be too sure of yourself, right? So elevated hemoglobin, A2, normal ferritin, high reticulocyte count, low ferritin. What's your answer? please. What's your answer? So the answer will be
Low ferritin.
low ferritin. We already know that. Elevated hemoglobin A2 is suggestive of thalassemia. Normal ferritin argues against iron deficiency anemia. High reticulocyte count is seen in patients who are bleeding and who are hemolyzing.